Hello friends, this is Nishant. It feels good to be back after a while, perhaps with an interesting topic that is hyponatremia, etiology and approach to the diagnosis. So without any delay, let's get started. These are my references for this video. First two are two really good papers for hyponatremia and the last one is a very good paper for assessment of volume status in critically ill patients. I am providing links to all three of them in the description section of this video. So what is hyponatremia? If we break it down into three words, hypo, natrium and emia, hypo is decreased, natrium is sodium and emia is basically in blood. So decreased sodium ion concentration in the blood is called as hyponatremia. So what is the normal range of sodium ion concentration in the blood? Yes, you got it right. 135 to 145 milliequivalents per liter. So, whenever the level of sodium ion falls below 135, we call it hyponatremia, as stated here. Based on the severity, hyponatremia is of three types: mild, moderate, and severe, with these being respective ranges. And based on chronicity, it is of two types: acute hyponatremia and chronic hyponatremia. This becomes very important during the treatment when choosing the treatment, because rapid correction of chronic hyponatremia can cause something called as osmotic demyelination. So it is very important to know this classification. So how do we approach a case of hyponatremia? There are usually three steps that will lead you to the diagnosis. Number one is the things you should be looking at is plasma osmolality. It can be increased, decreased, or normal. If it is increased, there is a different set of diagnosis. If it is normal, there is a different set of diagnosis. However, if it is decreased, you need to investigate further. If it is decreased, you need to look at the volume status of the patient. Now, if the volume status again can be hypervolemic, it can be hypovolemic, and it can be euvolemic. Depending on these three, you will get the diagnosis. Plasma osmolality can help us in narrowing down the differentials of hyponatremia to a significant extent. If the plasma osmolality is normal, what most likely we are looking at is called as pseudo hyponatremia. It is not a true hyponatremia, and it is due to interference of lipids or proteins with the measurement of sodium ion concentration. It is mostly seen with older instruments and is not true hyponatremia. So it is not as worrisome as the other two. Next one, if the plasma osmolality is high. If the plasma osmolality is high, the two conditions that we should have in our mind is hyperglycemia and if the patient is getting mannitol. If glucose or mannitol are in excessive amount in the blood, what they do is they raise the serum osmolality. This causes osmotic shift of water from cell to the blood. What this results in is basically dilution of blood. The sodium concentration decreases because the amount of sodium is constant and we are adding more water to the blood. So this results into again hyponatremia. Then if the plasma osmolality is low, then however the diagnosis list is slightly bigger. It is true hyponatremia, and it becomes very important to assess volume status in these patients. Assessing volume status becomes very important when we encounter a hypoosmolar hyponatremia. So, on physical exam, if you see jugular venous distension, S3 gallop, lung crackles, or pedal edema, you can say that the patient is hypervolemic. If you see a loss of skin turgor, you can say that the patient is hypovolemic. Orthostatics are group of maneuvers that are done to figure out if the patient is volume up, volume down, or if he is euvolemic. I have added a very nice reference in the description section of this video If you want to read about orthostatics in detail, you can refer to that. If you, however, want to objectively assess for volume status, what you can do is you can look at fractional excretion of sodium and fractional excretion of urea. If the fractional excretion of sodium is less than 1% and the fractional excretion of urea is less than 35%, you can say that the patient is volume down. Now, why are these two indices? So, suppose if the patient is on diuretics, it is expected that fractional excretion of sodium might be more and he still might be volume down. For that, you can, if the patient is on diuretics, you can use fractional excretion of urea as a marker for objective assessment of volume status. So depending on volume status, if the patient is hypovolemic, then you should look at urine sodium. Now, if urine sodium is more than 20 milliequivalents, it means that it is diuretics that is causing the hyponatremia. If the urine sodium is less than 20, it means the kidney is functioning fine. There is some volume loss in the form of vomiting or diarrhea, or say any bleed. So these two are very important causes of hyponatremia. Diuretics account for a large number of iatrogenic hyponatremias. Then if the patient is hypervolemic, that is if you see pedal edema, lung crackles, jugular venous distension, S3 gallop, it is one of these three. These three are very common or three common causes of hypervolemic hyponatremia: congestive heart failure, nephrotic syndrome, and liver cirrhosis. If the patient, however, is euvolemic, you should have four conditions in your mind. Number one, SIADH, that is syndrome of inappropriate ADH secretion. Psychogenic polydipsia, that is basically a patient is drinking a lot of water. And two other endocrine conditions are hypothyroidism and cortisol deficiency. Before you make a diagnosis of any of these two, it is important to rule out these two. So, these four are basically causes of euvolemic hyponatremia. So, how to differentiate between SIADH and psychogenic polydipsia? So, what you can do is you can check for urine osmolality. If the urine osmolality is decreased, that is, if it is less than 200 milliosmoles per kg, most likely you are dealing with psychogenic polydipsia. And if the urine osmolality is increased, most likely you are dealing with SIADH, that is more than 250 milliosmoles per kg. How do you explain this? So, if in SIADH there is more ADH hormone than required, so what is happening is more water is getting absorbed at the tubular levels in kidney. That is why urine will be more concentrated and urine osmolality will be high, that is more than 250. In psychogenic polydipsia, however, kidneys are functioning well, everything is fine, ADH is fine, but there is excess water. So you want to get rid of that water. So what happens is urine is dilute. So urine osmolality is less than 200 and very often it is as dilute as 50 milliosmoles. 50 milliosmoles. So this is how you approach hyponatremia. Thank you for watching my video. If you liked the video, please like, share and subscribe. If you have any questions, concerns or doubt, feel free to reach me at love.intmed@gmail.com. Again, thank you so much.